Good morning, everyone. I hope everyone can hear me at the back. First of all, I could just say thank you for the invitation. It's a great pleasure to be here, to be able to speak. I think this is a great couple of days for you guys, both in terms of the careers yesterday as well as today's conference, and I think it's fantastic that so many of you are here. So I'm very privileged to be able to speak to you this morning. What I'd like to try and talk about is looking at how we can evaluate the different restorative options and the prognosis of teeth. And within that, I'll talk a little bit about our restorative techniques this morning. I will, as Ian has already so eruditely done, talk a little bit about how we can communicate with our patients about that, because I think that's difficult for everyone, be that seasoned practitioners, new graduates, and I think conveying to patients prognosis and risk is a difficult thing for any of us. And so hopefully we'll be able to challenge some of the ways that we can do that with patients this morning. Also talk about how we can increase their awareness of problems, and then some specific risk assessment and how we can look at that. I would probably also say with that as a disclaimer that I don't profess for a minute to have all the answers to this. I think this is really a tricky area, and I think this is just my personal take on how I would do it and how there might be some helpful tips for you guys. I do have to say, dental protection and legal issues and things, I have to have a declaration. I do undertake some implant training for an implant company, for which you will see pictures, but I'm not having any shares in the company, and I've had sponsorship from 2 other companies for research that I've done at the Eastman, but again, I'm not directly paid by them, but I think put that out in the open and just declare that. But I think some of this was discussed yesterday. It was a really interesting day yesterday for those of you that were there. And there are lots of challenges for us in restorative dentistry. Ian touched on the perio challenges, but I think this is a fantastic area to be in. I love restorative, and I think when I look at what we've got coming in the next 15, 20 years, there are a huge number of things that are going to challenge us, give us lots of work to do, give us difficulties, but also a lot of pleasure, I hope, as well. We've got the baby boomers. Some of them are in here. I'm not going to point them out. They know who they are. And they're going to be a great challenge for us, as we know. We've got an increasing life expectancy with an increasingly dentate population. Far few edentulous patients. And we've got other issues. Patients getting older, they're living longer, they're on medications that affect saliva flow, increasing caries risk, lots of things that provide great challenges for us as restorative dentists. So I do think in lots of ways there are lots of great challenges ahead. Communication remains a big challenge for all of us, and I think that's whether or not it's new graduates like you guys or whether it's older guys as well. Communication is always a tricky thing, and we never got that much of it at dental school. And it's always something we seem to acquire once we're actually at the coalface and actually doing the work, and I think that's tricky. You don't rarely see pictures of a heavily filled dentition along with, I can't remember who this is now. Someone help me out. Kiss, yes, that's who it is. And shows how to get it for this picture. And they don't normally go together, but obviously going back to the baby boomers and that heavy metal generation, we see lots of mouths like this. I know one of them in the front row. Big, heavy amalgams, heavily restored, very little residual tooth tissue. When things need replacing, it's very difficult to know what are we going to do with those. Are we going to put another amalgam in? Is there enough tooth there? How many have seen cusps that have just sheared off, leaving what's left there and not having very much tooth structure? And that makes life really, really difficult. And again, it's these type of patients that you and I are going to be treating in the next few years as some of those restorations start to fail, especially with all the other risks that those patients will have. And there's some pretty interesting data when you look at this. I think this is spectacular. This graph here looks at, this is quite old now, it's 10 years old. Obviously the green and the blue lines are looking at the 60 and 70-year-old patient demographic, and you can see how they're disappearing up. And this graph down here looks at the number of people in the population that are going to get a telegram from the Queen. And that is pretty amazing. So we're somewhere here now. So even in 10 years' time, that's probably going to go up 3 or 4-fold. So patients are going to be with us for a lot longer with all of those challenges, perhaps with reduced capacity to clean their own teeth, to look after their own home care, and lots of these things have a big long-term issue on restorative dentistry. I love this saying as well, the senior tsunami, because that's what's coming and the way it's changing the dynamics of restorative dentistry. These are some American statistics, but they talk about the current baby boomers, and the population will reach as high as 79 million during the career of current dental graduates. And again, all of those implications have massive effects for us and in terms of what we do with regard to restorative dentistry. But as I said, in terms of tooth replacement, and what I really want to focus on this morning, given that we've done a lot of perio already, is really our decision making around endodontically treated teeth, about whether to, as we say, restore, whether we extract and think about an implant. I'm not going to give you any magic tooth replacement options because I don't have any. What I really think I would like to do is try and talk about restorative dentistry as a whole, because we are all restorative dentists. And I don't think it matters whether you're a specialist. What I do is no different to what you guys do. You're restorative dentists, and that's what you're treating every day, and that's really important. I do have a particular bugbear about this idea of cosmetic dentists. Lots of people will talk about that. I find that insulting because it implies to me, and I'm not a cosmetic dentist, but if I'm doing restorative dentistry, am I trying to make it look bad because they're doing the nice stuff? And these guys that are out there and saying, this is the only I do veneers or only do bleaching, whatever, we're restorative dentists, and that's a really important philosophy for me. I also don't believe in implantologists. So going back to this idea of every space you see is going to be an implant space, the old square peg in a round hole. I think implants are a crucial part of restorative dentistry and are really valuable in some indications, but they're just another part of restorative dentistry. It's no different to crown and bridge or a denture, it's just another part. Yes, there might be some increased training that we need, and perhaps as undergraduates we don't have enough of that at the current time, but surely that will change. But my worry is with some of these concepts is that we're providing treatment at the exclusion of all others, and that can't be right, because we're probably not giving a balanced view from that point of view. And we'll certainly see patients that, dentists that might wear t-shirts like that. And I put Bart Simpson up there, we all know who he is. And I think this is a really important point. You look at him and he's got bad Bart on his left shoulder and good Bart on his right. And we all know where we sit with that, don't we? But what I'm trying to get across with this idea is that when we're doing things in the practice, wherever we work and whatever field we work, it's about having that idea that am I doing the right thing by this patient? And every so often patients will push us to try and do something that perhaps we don't want to do. And we'll have bad Bart on our left shoulder saying, go on, just do it. We'll just go on and do that. And then we've got good Bart on the left shoulder going, no, I don't think that's a good idea. It's Homer, sorry, yes, forgive me. I don't watch The Simpsons. It is Homer, forgive me. But you know what I mean. And I think what I say with that is if we're ever pushed, and any of you guys are pushed into doing treatment that you feel you don't want to do, what I would do is I'd put a colleague on my shoulder instead, and I think, well, who did I trust at uni? Put him on my shoulder, and I'll ask him or her, would they be doing this in my position? And if the answer comes back in my head, no, why the hell am I doing it? And why am I being pushed into this position? So I do think patients can make us view things in different ways, and I think it's very important we do have that idea that we've got someone there. Think about, what would a colleague in my position think? Will they be doing the same thing? Will they say, Nick, you're mad, what are you thinking about doing that for? And if that's the case, don't do it. And again, you can extrapolate that and ask your trainers, ask another more experienced colleague in the practice. And some of you may have seen this slide yesterday. I'm grateful for a colleague for lending this, but we can see bad Homer and what t-shirt he wears here, because we've got an awful lot of implants in an awful lot of places. I think he got mixed up because I think we mistook the mental foramen for an osteotomy down there, so I suspect that lip was numb. But that's pretty much overkill, isn't it? And this is going back to, I'm an implantologist, I only do implants, and I do lots of them when I do them. But whether that's the right thing. And that can change because you can take that to crown and bridge work. Now we look at these and you might look at those and say, my God, what were they doing when they provided that work? I think ambitious would be a kind way to describe that. We've got multiple units, multiple abutments, we've got very compromised teeth, root fillings of sorts, posts, extensive bridge work. And again, if I said that both of these were provided in the last 2 years, so these have been done recently, and again, the practice that I see, one of these cases is an Eastern European case, but extensive dentistry. And in terms of the patients, when they fail, they're going to fail pretty catastrophically, aren't they? The patient's not going to be left with a huge amount when they go. And this idea of biological cost and when things fail, how things fail, is a really important aspect of restorative dentistry and in terms of what we're talking about. But in terms of that overall restorative philosophy, obviously encompassing all of our treatment options is really important, and also bearing in mind that different cases are going to need a different approach. So implants are not for everyone. They're not going to be for everyone financially because they are expensive. They're not going to be for everyone from a medical point of view, advent of bisphosphonates and things like that. There are risks with implants and things like that. So every case is different, and as restorative dentists, as you and I are, when we treatment plan those cases, every case must be treated on its merits for that reason. And again, Ian talked about this earlier on, never be afraid to ask for a second opinion. And we have SHOs at the Eastman, and they come, and one of them a couple of years ago was saying, well, I was encouraged not to obtain opinions because I needed to make my own decisions. And yes, you've got to stand on your own 2 feet and make a call, but I think that's an incredibly bad attitude to be purveying. There is nothing wrong with asking for a second opinion. It's normal ethical dentistry. Ask a colleague, ask your trainer, make sure if you're not sure, take some casts, take it away from the patients if they're not there, but never ever be afraid to ask for that second opinion. I ask for second opinions all the time, as do consultant colleagues where I work. And we'll take a case, we'll go and ask someone, have I got this right? What do you think? What would you do here? And there is nothing wrong with it. It's normal, ethical dentistry, and I think that's really, really important. So what do we want in terms of our restorative dentistry? Hopefully, I think we're looking for success, good prognosis, hopefully patients with happy, high quality of technical work, ideally low cost, especially with the price of gold at the moment and things like that. Job satisfaction, for me, that's probably the most important. And obviously, we want happy patients, things like that, but we want to enjoy our jobs, don't we? We want to be encouraged to do more, encouraged to do better work, encouraged to be interested in what we do, and obviously enjoy it, because it's not a job if we enjoy it, as everyone says. Our patients do want slightly different things. They absolutely want to trust us. They want health. They absolutely want low financial outlay. We all know that. And ideally, I think most patients now are coming across the ideas of minimum intervention, obviously pain-free dentistry, long-lasting restorations, and we'll talk a bit more about that in a moment. And they want to be informed as well. And I think that's a big difference. We talk about the baby boomers. Are the baby boomers, so this generation, there's an amazing statistic I read the other week that the baby boomers, and I think they describe that as a 14, 15-year cohort of people after the Second World War, they own over 90% of property in the UK. That is breathtaking. But this is an informed, affluent generation. They are not going to accept 21st birthday, all your teeth out and a set of completes. They are educated people generally. They have, a lot of them will be a lot more affluent than their forebears, and they have expectations that go along with that. And again, we're going to be the ones trying to deliver that to them. And again, I think that's important to be aware of. So when we plan expectations, we need to make sure that people aren't trying to be something they're not. And I think the first idea with that is that we don't want to be giving them the idea that dentistry is going to last forever, because that is our first mistake, because it doesn't. There are lots of new materials out there that come out, and you see the advert, and those of you that went to Dental Protection's Premier Symposium before Christmas, Trevor Burke spoke about the idea that a lot of materials come to market, they're heavily advertised, they're out there, they're in the dental comics, they're advertised in the BDJ, wherever it is, and they're out there. When you look at the evidence behind those materials in clinical success, there is none. And again, we have to be very careful. We're scientists as well as clinicians. Is there evidence to support these new materials? Because patients now come in and say, oh, I've seen this new ceramic system, I want to have this in my mouth. And they're much more informed, the internet, social media, all those kind of things. And we have to be aware of this commercial pressure of new products. Adding on to that, that other well peer-reviewed publication, the Daily Mail, I like this. We all know who this lady is. And I think you never thought she'd be an advert for cosmetic dentistry, for conservative dentistry, but maybe she might be. And this is what she says: of her dental work, veneers are the most painful surgery I've ever had. I have to have an anaesthetic just to get my teeth cleaned. I would never advise anyone to get veneers done. And I would imagine Katie Price is relatively well informed to make the judgment on cosmetic surgery, given what she's done. But again, a potential advert for conservative dentistry. So before I talk a little bit more about making our treatment plan decisions, I just want to touch briefly on consent. We've already again heard this morning about how we consent our patients. And I think it's important just to reiterate that consent is our patient's informed permission to undertake a prescribed treatment, obviously making sure that we've given them an appropriate and reasonable amount of information and a full explanation of what is involved. What consent is absolutely not is a waiver of risk or responsibility on the part of the patient. It's okay that those veneers fell off 3 weeks later because I told her they might. That's not good enough. That's not consent. And so consent is not a way for the patient just to be forgiven anything that might happen. It's not a permission for premature failure, and it can never justify inappropriate treatment. And that goes back to Homer, and good Homer and bad Homer, and where they sit on your shoulders, and what would a colleague do in that same situation. So myth number one that I would like to talk about is about the permanency of restorative dentistry. And I think I'm an optimist. My glass is always half full, but I tell patients that failure starts at fit. Not necessarily a practice builder, and I mean that tongue-in-cheek, but restorative dentistry will not last forever. The only way it will last forever is if the patient takes it to the grave, because everything else is going to have a finite lifespan. We know that, but our patients need to know that, and it's really important we communicate that to patients. That might be in a percentage term, so a number of restorations will last 10 years, one way of doing it. That might say, you might give a rough idea of the average lifespan based on the literature. You might do audits of your own work and have an idea of how long they last with you. That's another good way to do it. But things like final, permanent, guaranteed are not helpful. They're not helpful to patients when they perceive they're having that, because I've had patients, they always say, Once I have it done, that's it done for good. And that's their brain turning off that I don't need to worry about this again. I don't need to maintain it. It's done once, it's done forever, and I haven't got to worry about it again. And I think that's a real worry. Now, I consider myself a restorative dentist, as I say. My work is predominantly fixed and removable prosthodontics. And I think prosto comes a little bit further down the line. Yes, we're going to talk about replacing teeth, but the restorative foundations that I would regard would be the top 4 there. So prevention, number 1, and we'll talk about that in a moment. But the perio-endo aspects, as well as the occlusal aspects. And I think that's crucially important. Before we embark on any more complicated restorative dentistry, have we got the foundations that are going to give us the stable foundation to build our restorative plan on? And if we haven't, let's address those first. I think with prosthodontics especially, we have this issue of why patients lose teeth. There are candidates that are, patients that are not going to be candidates for complex restorative dentistry. And again, that's one probably to send over to Ian. But have we got the primary disease controlled? Why has that patient lost teeth? And that's always a big consideration. Is it caries? Is it perio? And what have I done to address those areas? Because that's really important. And how will that potential risk factor impact on my long-term treatment plan? So are they periosusceptible? Have they got a high caries rate? Is that to do with medication? Is that because of their diet that they don't know about? Have I done a diet sheet? And a lot of these things people say, oh, diet sheets, yeah, I remember those. We did those at uni. But diet sheets are an unbelievably good way of informing patients about risk and about cariogenic risk and what they have. How many patients, when you ask them, do you have lots of sugar in your diet? No. I don't have much sweets, so I don't drink Coke. Do you drink tea and coffee? Yes. And do you have sugar in your tea and coffee? Yes. Oh, does that count? And they have 8 cups of tea and coffee a day. So hidden sugars in diet is a really important thing. We need to know that's going to affect long-term prognosis of what we provide on teeth, and that's important. So diet assessment and reassessment. So I do it once and I'll recheck it as well. So 6 months in, let's do it again and check that they haven't changed their ways and gone back to what they were doing. Preventative measures, we all know that. I'm not going to focus too much on that. You all know what we can use in terms of higher fluoride concentrations that the patient can use, that we can use, that hygienists can use, and all of those are really helpful. And again, in terms of how we assess the complexity of cases, we look at the patient-related factors, and we've again talked about medical history, about access and about disease risk, and that's really important. And then they need to be drawn into the patient's overall expectations of treatment. So let's not just focus on those for us. Let's work out some risk factors, inform the patient about them, and then make a treatment plan based on those risk factors. And again, I think that's the difficult thing that we'll try and talk about now, and that's certainly what I want to come from when we do that. Now, diagnostically, when you and I do restorative dentistry, be it endo or perio, there are going to be things that we look at. We might look at the severity of the disease. We might look at a difficult occlusal case, class 2 div 2, no restorative space, a really steep guidance. And you and I will look at those and go, oh, well, that might be an issue, that might be a problem. We might look at that kind of 90-degree root curvature on that upper 6 mesiobuccal root and worry that we might not get around that. And again, they are important things that we need to know as part of our diagnosis. And again, sometimes that can be helpful to convey that to the patient. Let them know this is a difficult one, rather than just wearing that yourself and not sharing that with the patient. In terms of how we assess risk, I've tried to think about a way that we can do this and look at some cases which we will do in the latter part of this presentation. And so easiest way I can do this is a traffic light system. And again, we've got the slightly evil looking red ones, and I would call those the alarm bell cases. So they're the ones that there's a little alarm bell ringing. Do I really want to do this? Should this be the one that I refer, or I don't dive in and do a hit and hope because it's probably not going to work? Amber is the more difficult one because you could and you couldn't, and green should be pretty straightforward, obviously taking into a fact biological, financial considerations, because there will always be a financial consideration, and I'm very conscious of that. You can't do this talking about implants without bringing that in, because implants are expensive. Saying that, doing detailed endodontic work with new posts and new crowns and crown lengthening, that's going to be expensive too. And again, patients need to know that there is a value associated to that, and I think it's wrong if we don't address that as well. Now, in terms of evaluating risk and traffic lights, this is from Straumann, one of the other implant companies, and they do this quite nicely actually in terms of implant cases and implant work, and they try and categorise different aspects of a case that might put the patient into a higher risk category, and I think that's really helpful. And we've tried to introduce this at the Eastman with our postgraduates, so that when they look at a case, they are trying to look at those aspects of the case that potentially might put that patient in a higher risk. Is it high smile line? Is it thin biotype? Are they one of those patients that lifts their lip up in the mirror? Because you kind of worry about those, don't you? And all of these things are helpful for us to be able to say, this is green, this is straightforward, it's non-aesthetic, there's lots of bone, the nerve is low, good dentition, well maintained. That's a low risk case, as opposed to the high smile lines with thin biotype with an existing apical lesion that might need grafting. And again, potentially we leave the patient worse off if things don't go to plan. And I think that's a helpful way to do it. One other way to look at that is the Restorative Dentistry Index of Treatment Need. Ian touched on this earlier on. This is quite an old document now. It's amazing how little publicity this has had. And it really splits up the idea of the different monospecialty areas, so prosto, perio, endo, and it splits prosto into fixed and removable as well. This was designed to be a bit like an IOTN or a BPE for restorative dentistry. It doesn't really work like that. It's a bit clunky. That's a bit too complicated because I don't even understand or work all of that out. What it does do within the document, and this document is on your credit card sticks as well, is it does highlight some of the risk factors and some of the modifying factors that may be around. So I think this pertains to perio assessment, so we can see the case complexity. Again, we talked about this, so surgical cases, potential aggressive cases, non-responding cases. And we've also got other issues that might affect clinical management, drug interactions, dyscrasias, previous radiotherapy. And this is quite a nice document just to read, highlights, a few pages of A4, just to look at potential complexity and how that might affect the case that you're treating. So what can we do when we've got that? Obviously, if there is a case complexity there, communicate it, tell the patient this is a difficult case because, and when I would report on a radiograph, I would always put those difficult factors down, because what I want to try and do is make sure that I have documented down what I perceive to be the risk factors, and I will show you how I do that in a couple of moments. So moving on now to really tooth replacement and looking at a little bit more at the in-depth aspect of that. When I trained up at Newcastle, and I remember when we went into exams, we were told there's a space, that's the thing you wheel out. You were always told to wheel out, what would you do to restore this space, Mr. Lewis? I'd do nothing. That was always the first answer, which was always crazy. I could never understand why we do that. And then we had to go through removable because it was quicker and easier. Fixed, implants were kind of this holy grail thing that we didn't really talk about. We knew about them, but they didn't really happen. And certainly in the training that I did, we totally flipped that on its head. And certainly what we teach postgraduates where I work is a very different approach to that. And we don't do very much conventional bridge work where I work. The majority of it is adhesive work. We do place implants for cases like hypodontia and things like that. And really what we're looking at doing, and our restorative principles behind that, go back to the idea of conserving tooth structure, number one. Remember Schillingberg and that kind of name from the dim and distant past. Conservation of tooth structure, absolutely imperative. But we want predictability and we want retrievability. And that's why really adhesive work and implants as standalone restorative options provide us with that. That's not to say that conventional bridge work doesn't work well, because it can do. When done well, it's got really good success rates. But there are risk factors that we know, whether it's endodontically treated teeth or posts, that potentially threaten that long-term survival. And again, I'll look at that a little bit later on as well. And in terms of how I would do that for my patients as well, we do something called a 10-year survival assessment. So when we look at an overall restorative case, my brain is trying to get around, right, which of these teeth can I pretty much put my mortgage on the fact it's going to be there in 10 years? And they're the ones that I can focus my treatment plan around. If I've got that dodgy endo that's been redone twice and it's got a post in that might be linking and can't quite see it as an area, they're not the teeth that I want to be banking on to be there in 10 years, because they probably won't be. And so we try and have this strategic assessment of what's there so that we can focus our treatment plan and try and make sure that the maintenance of the patient as well as the long-term prognosis of those teeth is stabilised. So our risk assessment goes, why has the patient lost teeth? And is the risk then going to increase with the treatment I provide? That's really important. And we must get those restorative foundations right. All of these references are obviously in your handouts as well and on a stick. So this is an implant study, and this is important to hear that straight away. This is an American study that talks about how the prognosis of any restoration should be how we treatment plan a case. And I wouldn't necessarily wholly subscribe to that, but it's quite an interesting article to read from that respect. And it talks about how prognosis dictates therapy, and about how until we communicate with our patients about being realistic about longevity of restorations, it's going to be difficult because of this idea of permanence, which doesn't exist within dentistry. So I would commend that article to you. Failure, as I've said, is inevitable. We must look at how things are going to fail in the future. Can we possibly plan for failure in the future? and look at what the long-term cost benefit is going to be, because when we talk about endo and implants, as we're going to in a second, implants have a high initial financial outlay for the patient. Endo tends to be lower, but it's still going to be a financial outlay. Then the difficulty is if that then fails, which the numbers say it will do or may do at some point, that patient may then be committed to going down the implant route anyway. So you're almost not quite doubling it, but certainly increasing it. And it's really how things fail in the longer term that is probably the most important thing. And that's what's so difficult when we look at assessing prognosis, because patients will ask you all the time, how long is this going to last? And are you going to quote Albrechtson's study? Fantastic operator. A lot of the studies are done in secondary care institutions. Very few are done from a general practice environment. So is that comparable? If I quote Branemart's work, am I quoting the right thing for my patients? Should we do audits of our own work? Yes, is probably the answer. Look at your own work. How long have they lasted? What problems have they had? So at least we're quoting patient stuff that we've done. But that's going to take time to do. I know dental protection probably won't like this. That little blue sign up there is a little, perhaps, aid memoir that there might be something in your feedback sheet that relates to this slide. So if you need to answer questions, and I'm expecting a flurry of paper, that little blue slide might be a helpful aid memoir to do that. But how long will it last is an interesting one, because lifespans are based on the relevant evidence, and we'll talk about this study a bit later on. Endodontic retreatments, for example, have a lower success rate than conventional retreatments, and this is an excellent systematic review by Paula Ng and Kishore Gulabivala that look in pretty much at every detailed factor for endodontic success. But we do need to be careful how we quote that to our patients for that reason. So, implants versus endo. Myth number 2, have it out and have an implant. I see lots of patients on referral, number of whom will come in with failing or partially failed endodontic treatments, and they say, I would like to have this out and have an implant. As I say, I'm a restorative dentist. I do place quite a lot of implants, but I do quite a lot of endo. And we often have this joke at these minutes, probably a good person to be putting implants in is an endodontist, because I think you're probably coming at it from a very balanced view. Can I retreat this tooth predictably? Because endodontists can pretty much retreat anything, as you're going to see in a second. But a very balanced view is that, and this draws away from the idea, I just put implants in, so yes, that's a failed retreatment. I'll take it out and I'll put an implant in because that's what I do. Implants can work fantastically well, but so can endo. And really, I think the difficulty with endo is what we've got on top because of the amount of remaining coronal tooth structure, which tends to be the bigger thing. But implants are not without problems themselves. Yes, they can work very well. Yes, they have good success rate, but they have a high maintenance to them as well. And any person that does implants over a long period of time will see the maintenance factors associated with implants. And again, the patients need to know about that because there may be cost implications for the patient with that. Screws loosen, things break. Implants fail as well. They don't work all of the time. And we mustn't have this idea that implants are 100% because they're not. They come out, we can get adverse soft tissue reactions. So again, we talked about patients on phenytoin, calcium channel blockers. This patient was on one of those and was getting a nasty soft tissue reaction around an implant. Patients who I would say shouldn't have implants, if they can't keep that clean, they're not in a great position. And again, this was referred in, but again, that's a pretty nasty thing when you see that high-end restorative dentistry with that level of home care around it. But implants fail as well. This is an implant. This is my implant nightmare lady. This is the top of that implant when it fractured. So this lady has fractured an implant within her mouth. That is not a usable implant anymore. So implants have long-term maintenance implications. And this lady had all her natural teeth taken out with root fillings and post crowns, had a full mouth of implants, and it was the pot of gold at the end of the rainbow. It was going to be fantastic. And she has had nothing but nightmare problems. She's broken everything. She's broken implants, implant screws, gold bars. She's broken chrome dentures. She's a Pilates teacher, and she says that she's not at all stressed. And I would absolutely take difference to that. But nightmare. So we must remember implants are not a panacea. They have problems, the same thing with them. So sometimes that might be something to consider. And again, a balanced view, taking into account everything else, but that's often sometimes an easier thing to do, and possibly for the patient to keep a tooth. If I could have a root-treated tooth, well done, with a crown on, I'd have that over an implant any day. My tooth, periodontal ligament, innovation, all of those things are really important. And yes, implants work well, and we know that in the right cases, they're predictable, can give us nice aesthetic results and happy patients. And yeah, that's great, but they are not the one solution to everything. So in terms of communicating risks, and again, I don't want to repeat what Ian has said, but there is some crossover here, and I think it's good that there is. Any discussion I have with the patient is going to go in the notes. So document it, and I'll document that every time I do it as well. So I'm not just going to do it once. So if we do re-cement that crown on a dodgy post, the patient must be aware of those risks and issues and what the long-term management options might be. And every time they see the patient ad nauseum, I will tell them again, and I'll document it again, so that we're reinforcing that. I think the use of information sheets is invaluable, whether it's perio or endodontic risks or implant risks, whatever. I use these an awful lot for all of my patients when they consent to treatment. And again, going back to consent is everything, isn't it? It's not that piece of paper they sign immediately before they have their 8 out or before they have the implant placed. It's what you do at assessment, what you document, the discussion you have, the information sheet, the letter I write them. Yes, I get them to sign a sheet before surgery, but that's just to make me feel better probably. The biggest thing I give patients is a written treatment plan with risks, benefits, alternative options, an information sheet, and I give them websites as well. So I have a practice website that they can look at different treatments on. You can also give them some of the specialist societies that have very good websites that are specifically done for patients that talk about nature of disease, etiology, nice pictorials. And again, I give the patient those websites and then I ask them if they've had a look at them, and I will document that. Another way of just trying to get across what have I tried to do to give this patient more information. But again, there will always be those cases that when things fail and when the biological cost for those is high. And I remember this case specifically. And this is a case I treated at the Eastman, and I took that bridge out. Nice picture. This is a head and neck oncology case which I treat a lot. And you look at that, and again, it's difficult to take this in context because given what I'm talking about now, you might look at that and go, what an idiot. What was he thinking when he did that bridge? So we've got 2 abutments here. There was an abutment under here that had long since melted away. An enormous bridge that was mobile. And I took that out. The patient was being seen for oncology reasons. And I gave him a denture. And he died of cancer 6 months later. And his radiotherapy, his cancer treatment, none of that had a ranking on the scale compared to the denture I gave him, because he'd gone from a fixed prosthesis that had been in 20 odd years to a complete denture for all the right reasons, but the biological cost of that failure was enormous. He had a miserable last 6 months, largely down to me. I would do the same thing again because I did it for the right reasons, but the biological cost of that type of work is enormous, and that has a huge effect on patients. Talking about risk assessment, again, this is what I have as a standard, my normal consultation sheet. When I see a new patient, these are the normal things that I would record down. And again, these are in your handouts. And this is adapted a little bit from FGDP, a little bit from some of our Eastman stuff, and it just has the standard things that I talk about, but I think this next bit's really important. So on the second sheet, I have radiographic findings, other things, special tests, diagnoses. Again, reiterating, we can't have a treatment plan without a diagnosis, because if you haven't got a diagnosis, you can't make a treatment plan. So you must have a diagnosis. But at the bottom of this sheet, and I always do this, I then have an oral disease and restorative risk factors. So this is my little checklist to make sure that before I go to start treatment planning the patient, I will go back through the presentation, what they're complaining of, medical history, and have a think about what possible risk factors they've got, and I'll document those. And again, that then focuses my treatment to make damn sure that I'm addressing those preventative factors, making sure that the patient's aware that they're a bruxist and they're going to put higher forces on those restorations, making sure that they know they're periodontally susceptible. Perio information sheet, talk about the nature of disease. Talked about screening siblings as a family history, brothers, sisters, kids, all those other things. And again, that's the way that I would do it. Systemically, diabetics, bisphosphonates, other things, it's a jog, it's a memory jog. So before I do my treatment plan, I myself have got a risk assessment. I've picked out those things within that patient's history that worry me and that might have an effect on my restorative dentistry in the long term. So moving on now to what's predictably restorable and what's not. Obviously, we know that in terms of the work that we do, endodontically, we need intact dentine. And if in doubt, we need to potentially remove what's there, remove a crown and investigate the tooth. And endodontists will always say they would do that routinely. It allows them to assess, is there undiagnosed caries, fractures, is there pulpal involvement, and have we got adequate remaining tooth structure? It's very difficult to stand here and say what is unrestorable. And I often say, not what is unrestorable, but what is predictably restorable, because we can restore pretty much anything. We can do posts, root fillings, we can put something down there, put some pins in, but predictable restoration is much more difficult if we're going to talk about longevity. But I would regard generally these as being unrestorable. Vertical root fractures we saw earlier on and we'll see again in a minute. There's not much we can do about those. They're pretty much goners, they're for the bucket. Inadequate coronal dentine, and again we'll talk a little bit about that in a second. If there's not enough tooth structures to support that restoration, you've got to question why you're doing it, because the success rate is going to be much, much lower. almost unacceptable, and I think we have to think why that is. Osseous caries, again, for me, is something that I would regard as being unrestorable. Yes, we can do things like crown lengthening. Not in every case. We're not going to expose furcations. Not every case is aesthetically amenable to crown lengthening because of altering gingival margins. It can be a way that we can improve things, but generally speaking, it's not for everyone. But things like this, and we've all got those, the post-crowns, and they're in every other week. Having it stuck back in, you warn them again, and out it comes a fortnight later. So again, predictably restorable, no. So from our traffic light system, that little nasty red man is up there thinking, well, I'm going to warn the patient. This isn't going to be something that's going to last. I think from a long-term restoration point of view, if we're going to think about things like implants, root fractures for me are something that you need to jump onto and get on with, get the tooth out, because they can have quite profound bone loss around them when there's that chronic infection over a longer period. So sometimes speak to someone who might be doing implants and things for you and talk about whether you should be getting that tooth out, and I think that's important. Teeth like this, you will all know about, we all know, we investigate, not really much we can do. Horizontal fractures will often present with things like the quite extensive bone loss. We talked about that J-shaped lesion around them. Again, I think most of us would know pretty much what's going on there, but that can be more difficult. Looks like a reasonable endo. You can see big J-shaped lesion going all the way around the tooth, pretty good indicator that in terms of what's there, we've got huge bone loss around the tooth. So root fractures are often something that we need to get on with and take out. And again, we will all see things like that. We investigate things. CT's made that a lot easier, and whether or not you're using those, it can be a really nice way to show up whether indeed there is a root fracture. Some of them are obviously less difficult to diagnose from that point of view. So in terms of endodontic assessment again, and making our assessment about whether we've got unrestorable teeth, inadequate coronal dentine is a big problem. You remember we talk about ferrules and amount of coronal dentine that we need to support everything. And again, if we haven't got that, it's going to be difficult to try and restore something on top. In terms of when to extract, and I think that's a difficult decision for you guys to do, but again, going back to those things that I would deem to be unrestorable, I would generally say that if a tooth is asymptomatic with a no acute pathology, you can leave it there, maybe refer it first. People who are doing implants will often like to take the tooth out themselves. And I don't think that's a controlling thing. It's often that if there's a problem with that extraction, they can deal with that as they need to. And again, what you probably don't want is an apical third fracturing off, being left down there, and then it's a surgical to get it out and taking away the buccal plate. So if that happens to the person who's doing the implant, that's their prerogative and they can deal with that themselves. But it's probably something you would want them to be dealing with and not you. So maybe they are ones to refer. If a patient's got acute or recurrent symptoms, let's get them out of pain. Let's not worry about that. You want to get them out of their symptoms and get on with it. And as I said, chronic root fractures can lead to quite profound bone loss from that point of view. So I think sometimes we do need to dive onto that and do something with that. Cost benefit, and again, I didn't really want to put numbers in here, but I have done. We've got to weigh that up because that's important to patients. We know that's something that they will prioritise. And I've put some ballpark figures there. That's going to depend where you work and who is doing it for you. But what I really want to get across is that the initial outlay for an implant is obviously going to be more, as we all know, and taking into account things like the replacement tooth and the restoration. And obviously root canal, if it's just a root canal and a crown, is going to be much less. And for me, done well, probably better actually. But if we're going to start going down the road of crown lengthening, re-RCT, new post, new crown, that's going to be a fairly heavy outlay as well, based on the fact that our prognosis has also dropped. So there's also that risk that they could have all that done, write the check, not like that, then that fail, they're going to cross over to the left and still need that done anyway. So they're almost doubling their outlay. And again, sometimes that's helpful to communicate to patients so that they know what are the risks and benefits. And you will have people that will take a punt on things, life's gamblers, and they may well say, you know what, yeah, I'll go for keep the tooth and I'll take my risks on all that. And they do that hopefully from an informed decision so that they can do that. I said earlier on, endodontists can root fill anything. And now you're now going, please, God, no, tell me that someone hasn't done this. I'm grateful to a colleague for this picture, but yes, God knows why. Seriously, this is not PowerPoint, this is done. Nice root filling though, but my God, why? But they can root fill anything. But let's take that back. We're all restorative dentists. Why are we doing it? What's the benefit of doing it? But they'll get down anything. Terrible. Endo is another interesting area. These are some pictures, and when I look at this, and I do enjoy endo, I'm actually always astounded that endo ever actually works. I had a misspent youth at the Eastman. We used to have to take extracted teeth and put them through a chemical process whereby they become translucent, and we used to stick dye down them. And this is the Eastman's idea of fun in your spare time. But what it does show, these are fantastic pictures, but it shows us what a normal root canal anatomy is like. And so what we see on a two-dimensional radiograph is totally different to what we see down the root canals. And if you look at these premolars, it's a wonder anyone's root filling ever works, because we know that we're never going to get down most of those areas, and all we're really doing is getting something down to change the biological flora and clean what we can. And again, curves like this, interconnecting canals like this, accessory canals, really, really tricky, but it is an absolute miracle that endo works at all. Back to this idea of predictable restorability. Obviously, we assess the tooth before endodontic treatment's commenced. A rubber dam, forgive my typo, what's not restorable? If you can't get rubber dam on a tooth, it's probably not restorable. And again, rubber dam is a mandatory part of endodontics for me. It needs to go on there. We've got to protect everything, make sure things aren't getting in there. And from a medical legal point of view, it's the only way to be doing endodontics, really. But we must make that assessment as to what is predictably restorable. So we can see a case here, compromised tooth. I would say that's a sparse root canal and pretty much non-existent. We've got an enormous area here, haven't we? Probable root perforation with that post. So again, when we come back to doing our restorative assessment, we've got lots of things that we need to look at. What's the quality of the root canal? Have we got technical problems, zips, ledges? Have we got perforations? Do we need to investigate this tooth? Because have I got enough coronal dentine to restore? And that's normally the first question. Have I got enough tooth to put on top here before we even start a root canal treatment? So that we know that once we start that, we know that the restorative foundation is still sound, because that's really important. But again, when we look at cases like that, for me, that's a red. That's osseous caries, heavily restored tooth, probably with a predominance of core. It's got a failed endo, but that's not restorable. I can't crown lengthen that and not exposification. That's not restorable. That's coming out for me. Again, if we do our risk assessment, looking at this one, we can see that what we've got there, we've got defective adjacent tooth, we've got probable post-perforation, not a very nice root filling, big apical area, big loss of furcal bone loss as well. So again, for me, probably not a restorable tooth. So I'm going to be moving towards extraction on that basis. And it's really about going through those sequential things with all the teeth we do. Slightly different tooth this time. So no existing root canal treatment. We can see there are potential endodontic issues, whether that's hypocematosis, whatever, and we can see the root canal is not evident right to the end. But based on the tooth assessment, we've got reasonable, I would say, lingual and buccal walls on that tooth. Yes, we've got fairly compromised tooth structure mesially and distally, but I would say that tooth is restorable for me. Yes, there are issues. There may be risks. It may be an endodontic treatment to refer, but I would be relatively happy embarking on that with all the information that I've got. But again, in the way we do that risk assessment, that's an important thing. If we look at a green, slightly different case, so we can see a retreatment, and that might make things more difficult. You may be less confident taking on endodontic root treatments, as a lot of young dentists that I speak to are. But we can see from our assessment, we've got relatively good amount of tooth structure. We're compromised on one side, but I would be relatively happy that that is restorable, both from a restorative perspective as well as from the endo point of view. So that's a green for me. So I'd be happy to embark on that with that in mind. What we can do in order to protect things in terms of stage protection, sometimes teeth are weakened with endodontic treatment, so sometimes use of things like orthodontic bands can be really helpful. The worst thing in the world is you do a beautiful root treatment and they come back to have the crown done and then one of those cusps is just sheared off. That's not what any of us want. It can turn a good root treatment into an unrestorable tooth. So sometimes if those cusps are weakened, it used to be things like copper bands, old-fashioned dentistry but works and helps to protect that remaining tooth structure until you've got provisional and cuspal coverage on there. Again, nice, simple way to do things, maintaining the seal and also facilitating things like rubber dam isolation. Other things that we can do with compromised teeth, we've talked about the foundations. I'm going to talk a little bit about core build-ups before showing just a bit on post and a few case selections. And I'm going to talk a little bit about the Nia core. Much maligned, not valued often because it's amalgam and it's non-aesthetic, but a fantastic way to help try and restore those compromised teeth. Dentine pins have very much fallen out of fashion. We know that they can weaken the teeth, they create quite high internal stresses. And we know from a core material perspective, and again in terms of your handouts, you might want to think about one of the feedback questions on this one. Very good evidence, Kavaric study from a long time ago now. Amalgam and composite are fine for cores, GIC is not. So GIC is an inadequate core material. So it is not strong enough structurally. We know it doesn't retain strong enoughly. Yes, it's adhesive, but in terms of those alternative materials, amalgam and composite are very much what we should be adhering to from a restorative predictability point of view. And Kavaric's study well documented from that perspective. But in terms of our amalgams, I still use amalgam routinely. We will see for how long that is. Fantastic material for compromised teeth. It does allow us to build up an awful lot of tooth structure predictably. It's a strong material. Naya wrote the paper whereby we can utilize the root canals in order to pack into there so that we create some kind of macromechanical retention, and we can also overlay things as well. And we can see a simple case here of an amalgam core, slightly old-fashioned now, but a gold 3/4 crown. I'd say it's beautiful work. And again, very predictable. We've preserved tooth structure, it's cuspal coverage, we've retained the tooth and work very, very well. Yes, I accept gold is not as popular with patients, but a very predictable restoration, and my God, they last. They really do. They can last for an awful long time when we look at the evidence of those based around everything else. In terms of our risk of failure, again, we've talked about core materials. Chris Lynch's study back in 2004, and this is interesting, looked at the survival of root canal treated teeth over 3 years, and again, he talked about cast restorations, amalgam restorations, composite and temporaries, and we can see if we do a good root filling and we get something in there, be it amalgam or composite or a cast restoration, the success rate is much, much higher. If we leave temporary restorations in for protracted periods, even if the patient elects to do that, our failure rate drops down. So we've got to get these teeth restored, and again, that becomes important. So tell the patient, if we're undertaking treatment in the compromised teeth, inform the patient, alternative management options, and document it. As we said earlier on, if you're not comfortable doing endodontic treatment, you shouldn't be doing it. If it's a retreatment, if it's difficult anatomy, absolutely nothing wrong in getting that specialist referral, so refer it. If the patient elects not to have that referral, you document it, and that's the informed refusal we talked about as well, but document your discussion every time. In terms of assessing the tooth structure, this is difficult. This is a study done by one of my mentors, Derek Setchell at the Eastman. It's a really interesting study. I don't actually think this is very helpful in terms of tooth restorability. But what this study showed is that all of us, be it specialists, undergraduates, postgraduates, all of us as dentists, we overestimate the amount of remaining coronal tooth structure. So we look at a tooth with a big filling or composite and we go, yeah, that'll be all right. I can put a crown on that. But what we don't really appreciate is how much tooth is actually remaining there. And we talk about the referral rule and all those things. And this was an interesting study that looked at asking a whole group of dentists, would you be prepared to put a crown on this? And then what they did is they were able to take away, after preparation, what was actually left of that tooth after it was prepared for a crown, i.e. they showed what was left of that coronal dentine. And it was pretty shocking, and all of us were really surprised because we'd look at teeth and go, yeah, I'd definitely do a crown on that. And you'd look at what actually was left tooth-wise afterwards, and there really was very little. And it's no wonder that we might have premature failure when that can happen. But we know posteriorly, very good evidence, as you guys will all know as well, posterior teeth, occlusal trauma, heavily restored teeth at risk of cuspal fracture as a result of those lateral forces. And again, the difficult one I always think is those premolars. They have a huge difference in terms of where the restorations sit, and some of those we will say and go, yeah, I'd be pretty happy with those two. I think I could, if I did a root filling, I could put a crown on, probably be all right with that, although there might not be too much left. And again, it gets more difficult once you come down the other end, doesn't it? And we start looking at those and going, well, is there enough tooth structure there to put something on? Probably not, because by the time I prepped it, there's going to be nothing left. So do I then move towards a post? And I think that's where the difficult decision-making comes in. And we all have cases like that, don't we? Heavily restored MODs in those older patients, root canal treated, undermined cusps, and again, they're at risk of popping off, and again, really difficult to do. Nye cores, as I said, really helpful way to restore compromised teeth, utilising those pulp chambers, as you'll all be aware. We can overlay those as well. So if we're worried about small amounts of cusp fracturing off, we can overlay those. Full cuspal protection, long-term restoration as well. Very often, if a tooth is borderline restorable, I might leave it like that, and again, consent the patient to that. And potentially you can do those with composite, although we know the evidence isn't there to say that composite is strong enough to use the pulp chambers from that point of view. But certainly you can bond that on as another way of doing it. But overlaying the occlusion, a really helpful way to do that from that perspective. Again, when we talk about the causes of failure, we know that what we put on top as a restorative dentist is probably more important than the endo. So the endodontist can do all the fancy shapes and curves down the root canal, but what we put on top of that is probably more important. And we know from Ray and Trope's study back in the 90s that the coronal restoration was shown to be at least as important, if not more important. So the best root filling in the world is not immune to bugs getting back in. So we've got to have a coronal seal, and we've got to have something on there that then protects the tooth for you. Anteriorly, we know that's not the case. We can provide root treatment in a more straightforward way anteriorly, but we know that there is no evidence to say that in anterior teeth we need to provide crowns. It's fine to do that if it's justifiable from a restorative perspective, heavy restorations from a cosmetic point of view, whatever. But we know that there's not needed there from an endodontic point of view. And again, Sjogren's original study spoke very clearly about the other risks that we've got in terms of endodontic treatments, as opposed to vital cases where we've got a good success rate, 95%, right up there with implants. It drops a little bit when we've got established infection and a periapical lesion, but still good, predictable success rates that we can quote to patients. And again, Sjogren's was a big meta-analysis of lots of different studies. And I do think that is good evidence to be able to give to patients when we're talking about primary and secondary endodontic treatments. Retreatment tends to be an area that I know a lot of young graduates feel less comfortable doing. And again, I think that's difficult. Absolutely, they're the ones that you might want to refer. Obviously, my rules generally are, if I'm going to do a new restoration and I think the current filling is inadequate, I repeat it. If I think I can improve on it, I will repeat it. Talked about the amalgam earlier on. Take into account there may be a reason why that's not a very good root canal treatment, so always take care when you make that decision. But the other main indication for me will be where there's exposed GP. I have no way of knowing how long that's been exposed. The patient thinks they lost it last week, but they don't know. So I may say, I'm going to repeat that to make sure that, again, my restorative foundation is safe, secure, and is going to be working well from that point of view. But cost implications, as we've already looked at, RCT and implants are comparable. Yes, there are variations in cost, but generally speaking, they are comparable. We know, again, note the blue circle, we know that from an RCT success point of view versus implants, we can compare good quality studies, and they are absolutely comparable in terms of success rate. So I don't think we can sit here and say, you've got to have an endo, you've got to have an implant, because they are both recognised ways to restore teeth and both have good predictability when done well and in the right cases. Again, another good study, and I think this is the important thing, going back to consent and talking to patients. Yes, good success rate. Failure rate was identical in this study by Doyle. But what was really interesting is that when you look at the issues around implants in the longer term, a huge amount of maintenance, fractured crowns, fractured screws, screw loosening. We talk about periodontal disease, going to keep us in business for a long time. Ian's going to be kept in business with periimplantitis, no doubt, because that's probably the big time bomb waiting to bite everyone, because we look upwards 15–20% of implants may well get periimplantitis at some point, and from that point of view that can be incredibly difficult to manage, difficult to treat, and in the longer term can have a big impact on the long-term health of the patient in terms of losing implants and having more remedial work. But based on this study, endo done well has very minimal maintenance to it at that stage. So from that point of view, comparable success rates, initial cost is higher, as we've said, but the caveat to that, and again you've got to convey that to the patient, is that if that root treatment fails and they're running down the implant road at that stage, their overall cost is obviously going to be much higher. Posts, we know, have quite a high risk factor for teeth. I'm just coming into the last 5–10 minutes now. This is an American study again, but looked at the impact of 5-year survival. That's not great survival. I don't think many of us would say that we'd be looking for a 5-year survival. But we can see that posts, depending on what restorations are placed, have quite a big impact. So quite good on single teeth. We know that for denture abutments, they're an absolute risk. And again, we know that for removable partial denture abutments, again, it drops down even further. So a big no-no in many ways, because we know that we put those abutments at very high risk of failure with things like partial dentures. When we look at other evidence to support our conventional versus our implant dentistry, and whether to save or extract a tooth, this Greenstein study, and again, this is from some of the big doyens in America, and we have to take this, I think, with a slight pinch of salt, because the Americans do treatment plan things in a slightly different way. And they again showed that post-failure, we reported as high as 22% at 5 years. And again, this tends to be a paper that's pushing implants, but posts, we know, are a huge risk factor for teeth in the longer term. Again, another American study in your files, George Priest study, and he talked about implants being a benefit to the adjacent teeth. And again, this is a no-brainer, really. We look at why that would be a helpful thing, and the author, not surprisingly, concludes that if we don't have to cut adjacent teeth down, they're going to last longer. We know that if we have teeth adjacent to edentulous spaces that have a good prognosis, i.e. things like implants are placed, they're going to last longer. And the Americans talk about this idea that human beings will look after what they value. So this idea that if they spend more on it, they might look after it more. And again, I don't know if I totally subscribe to that. But again, something else to think about. But again, looking at cases, simple, high-quality restorative dentistry is really what we should be looking at. Again, patient that I saw, young chap, missing lateral incisor, obviously discoloured central, and he'd been referred in for veneers to manage this. This was obviously non-vital. We took it out, that was the offending article. Simple non-vital bleaching, brought the tooth colour up and an adhesive bridge. He already had one on the left side for missing lateral incisors. We tend to, at the Eastman, to take a very conservative view to adhesive dentistry. That's pretty much no prep, minimal no prep, and people will have different views on that. But conservative dentistry, preserving tooth structure, and again, going back to all those things that we kind of prioritise in terms of our overall restorative planning. And I think that's what the really important thing is when we look at these cases, because from the perspective of what we're trying to do in terms of tooth preservation, predictability, prognosis, I think that's very, very important in the longer term and as to how that runs. I'd just like to finish off just looking a little bit more at the post evidence and again some of the other options we've got for that. Again, I think we all know posts are not a strengthener of teeth in that they weaken teeth. Good evidence about that. It's the bulk of that remaining tooth structure that you and I both want as restorative dentists to give us good predictability with the crowns on the teeth. Again, with lots of different ways we can do posts and direct post patterns. We know that we need the ferrule, so viscoelastic studies. If we haven't got that ferrule, we know that there's a high risk that the posts are going to fracture. We know that cast posts may have a higher risk of debonding as opposed to fibre posts that might be bonded, but again, fibre posts will often fail with root fracture. So we know if we haven't got the ferrule, we put those teeth at a very high risk because of that. We can try and make life even more complicated and do two-part posts for compromised posterior teeth. I think that's probably moving into the realm of herodontics after re-root canal treatment, and this is again very Eastmanized. I do love the Eastman, but they are renowned for trying to make life as difficult as they can for you at times, and that's certainly why I did that, I'm sure. But the choice of post and core, whether it's cast or fibre, I don't think matters. You do it when you have to, when it's an absolute necessity, not because you feel it's strengthening the tooth, because we know that's not the case. And there's now better evidence coming out with fibre posts that that's a good way to do things, and again, absolutely fine. But again, I think from an overall idea of space maintenance, this was a case that was referred to me. This was a 16-year-old trauma. And if we apply the restorative risk factors that I talked about for this case, that's unrestorable pretty much for me. Not much coronal dentine, it's a subgingival fracture. I did restore it, but because she's 16, I could get something on there. It's still on there a couple of years later. If I can keep that root there as a natural space maintainer, I will, because that offers a better long-term prognosis, whatever I'm going to do, be it an adhesive bridge or potentially an implant further down the line when the growth has stopped. So I think all of these rules have to be taken in context. There will be times when it is okay to break the rules in the right way, telling the patient what the risks are. So this patient knew, as did mum, that this might not last forever. It might come off. But I do think for the right reasons we can justify not taking that tooth out and leaving that there from that point of view. So again, just to finish off, we talked about the endodontic risks and when to refer. And I think really this is what is helpful for you guys. So endodontically, when should you be thinking about referrals? Obviously, retreatments and post-removals I think is a reasonable thing not to expect individuals like yourself to want or have to do. Apical surgery, difficult root anatomy. And I think the bottom one for me is really, really important as well. We see lots of patients, and I certainly get them as well, from individuals that have had 3 or 4 or 5 root fillings and the pain's still there. And I think as soon as a root filling has been done and the pain history has not changed, that's got to start ringing an alarm bell that there may be something else going on. And again, get a second opinion. Refer in to a facial pain expert, refer into oral medicine. Is there something non-odontogenic going on here? Because it's horrible when you see these patients that have got a quadrant's worth of root fillings, sometimes with extractions as well. Their pain is unchanged. It's the same as it was on day one. And no one has quite clicked the fact that the 4th or the 5th endo still hasn't done the job. And they're looking for root fractures, they're looking for perio pockets, but something is not there. If it doesn't seem right, it often isn't. And again, so always think about just referring those if and when you need. Again, I haven't really focused too much on perio for the reasons we spoke about because of Ian's already covered that very well. Periodontal risks, we talked about aggressive cases, young patients when perhaps there isn't something for aggressive, there isn't a large amount of deposit, there isn't a huge amount of risk factors. Aggressive cases can be more tricky to treat. I think probably they are the remit of specialist care, so refer those on. Isolated and non-responsive defects and also perio lesions. And I would add in the third, and I think the often forgotten dental disease is obviously occlusion. And I say to patients, dentists as well, do think about if you've got multiple fractured teeth, those real parafunctional growths, get an opinion. Even if that's going to come back to you, get a specialist opinion. There's nothing wrong with that. Ask about it, get some advice, get a treatment plan. Those cases where we've lost anterior guidance where we've got lost posterior support can be really difficult to treat. And again, maybe they are ones that you can think about referring for and getting that second opinion. And so finally, we've talked a lot about complexity, and I hope I've tried to give you some ideas of how we might think about risk assessment with regard to that, to try and treat each case on its merit. We're restorative dentists, as I say, all of us, you and I. Whenever any of us feel uncomfortable with any aspect of our practice, don't do it. None of us should ever be forced into treating a patient, and I always say, just as patients can choose to come and see us, we should be able to choose which patients we treat as well. And if you're not happy with the patient because it's a personal thing or something else, never be afraid to say, you know what, I'm just not sure this is right, so I'm not going to do this one. I've done it, I don't do it a lot, but I do it sometimes. If I just get a feeling, I just back myself out straight away and say, I'm not going to do this. Referring, as I said, is a normal part of good ethical dentistry. Never let anyone tell you it isn't. It's right to get a second opinion. It's right to ask a colleague. Ask another one of your guys in the VT group. Ask your trainers. There is nothing wrong with that. I think that's good, normal ethical dentistry and sharing a problem. And really, I think not referring can very often be the start of problems, when perhaps you're trying to take it all on board yourself, being pushed into treatment plans, and that might be when things become more difficult. I'd like to again thank Dental Protection and the BDA for the invitation. I hope that very quick whiz through was of help, and thank you once again for attending.